Okay, so thank you everybody for coming to our Neonatal Hemodynamics and TME NPA Foundations curriculum lecture for the month of November. Dr. Yasser Al-Sayed is an associate professor of pediatrics at the University of Manitoba, a staff neonatologist and researcher at the Children's Hospital Research Institute of Manitoba. He's the director of the Integrated Hemodynamics and TME program and also the founder and the point of care ultrasound program in Winnipeg and the co-chair of the POCUS Neo group. So using a combination of ultrasound, echocardiography, and NIRS, he's been able to optimize the management of critically ill newborns by providing a thorough assessment of end organ performance. So we invited him here to talk about the T and echo assessment of the crashing infant. And I expect it to be a wonderfully educational session. So just a few housekeeping reminders. If you want to ask a question, if you are one of the webinar attendees, you will not have access to your microphone, your audio or video, so please put your questions in the Q&A box. The text box can sometimes get run over really quickly, and so the Q&A box will make sure that we don't miss those questions. For those of you that are panelists, you do have access to your microphone and your video, so if you'd like to turn that on or ask your question, that's okay. The recording in progress. The actual lecture is recorded. We will stop the recording after Dr. Al-Sayed is done, and during the Q&A session, that will not be recorded. So all of you are welcome to turn on your cameras at that time. So if there's nothing else, I don't think we will go ahead and get started. I'll hand it over to you, Dr. Al-Sayed.
Thank you very much, Dr. Rios, for the introduction and the organizing committee for inviting me. It's my pleasure to be here today with you. So I'm going ahead and start sharing the screen. Can you see the screen?
Yes, we can.
Okay. So today we are talking about the hemodynamics evaluation in a crashing infant. First, I have nothing to disclose in this presentation. And over the next 45 minutes, I will be talking about four main objectives. First, I will demonstrate the physiological mechanisms in acute instability in the neonate who is really crashing, and demonstrate the findings on T and echo related to the crashing infant, and then discuss the physiology and the T and echo findings related to cardiac tamponade and IDM, and I have case scenarios. And then introduce physiological instability seen in cases of cardiac arrhythmias. In this presentation, I'm focusing on the main concepts. I will not be talking about the techniques and the details of the measurements, because you need to attend workshops and hands-on to learn about that. But I will be talking about main concepts. And I will be more general about the hemodynamics concepts that are mandatory for the neonatologist, even those who are not really performing or doing echo on daily basis. So I have in this presentation a few sections, and I interrupted the sections by questions. So look at the question and try in a few seconds to digest the question before I answer over a few slides. And again, it is interactive. You can interrupt me, you can ask a question, or keep the question to the end, it's up to you. So the first question, why neonatal hemodynamics is mandatory? The simple answer of that, we have so many centers in North America and Europe and all over the world. They started neonatal hemodynamics as a program, and they are now considering that as standard of care. If you ask any member in the team, can we just go back to the previous era, not relying on detailed hemodynamics, the answer should be, or expected to be, no. So between life and death, we have a journey. We are working in intensive care, so we are interested to keep all of our admitted patients' cases stable And there is at the end unfavorable outcome, and the most unfavorable outcome, which is death. Between both, there is a journey, and our aim to break down the circle and to keep the infant stable. For any infant admitted in intensive care, there is early compensation for any issue which might be happening to respiratory or cardiovascular system, and it might be deteriorated to late, or compensated, but actually late before the actual decompensation happening, and typically organ failure before death. So in early compensation, we are interested to detect or predict issues at the beginning, not just let everything to be to proceed to late compensation or decompensation stage. And for early compensation, now we are using a technology by detecting issues or pathophysiology, looking at the organs by ultrasound or echocardiography, or doing MRI or MRA, near field spectroscopy, and evaluating the vital signs as a trends and histograms by continuous monitoring and getting more scores before you are at a later stage when you can detect only by vital signs late compensation. And the typical vital signs: heart rate, respiratory rate, temperature, blood pressure, oxygen saturation. And typical decompensation, which is unfavorable to see hypoxemia or hypoxia with lactic acidosis and significant hypoxemia, or hypoxemic respiratory failure. At the end, you'll see multi-organ failure and eventually death. So we need to break down the cycle and predict early. So be the predictor, not the diagnostic person to the issue when it is established. So the next question: how to identify the crashing infant? We are now talking in this presentation about the crashing neonate or the crashing infant. I'll just refer you to this article recently published early this year about using point of care ultrasound, including cardiac point of care ultrasound, which is different concept from detailed hemodynamics. And in this article, they have this algorithm of multi-organ assessment, including heart, and the indication or the indications to assess any infant considered to be crashing included 5 main indications: infant unresponsive to resuscitation, or infant at any stage of shock, either early compensated or decompensated, poor perfusion, acute hypoxemia, and unexplained acute anemia. I will just finish in a couple of slides: infant unresponsive to resuscitation. And we are talking about infant who is almost dying and you need to break the circle. And in this article, they considered 4 main mechanisms of infant who is crashing related to cardiac causes. So the next question now: what are the cardiac causes of unresponsiveness to resuscitation? So I'll just discuss the first indication for assessment of the infant who is crashing in relation to cardiac causes. So the article, 4 main mechanisms considered for infant who is crashing or really very sick and might be deteriorated over minutes, not even hours, for 4 main indications or causes. So the first one is poor contractility, and poor contractility in this concept is not actually just impaired contractility; it is very poor, and you may consider it as or call it as cardioplegia. And you need to start and be a little bit aggressive in giving inotropes, even as bolus is not as infusion at the beginning. And then cardiac tamponade related to significant pericardial effusion. So you need to do pericardiocentesis as soon as possible. Pulmonary hypertension. Now I'm talking about infant who is really very significant pulmonary hypertension with right side compressing left side. So compromised right side performance and also left side or systemic perfusion. Empty heart, which could be due to high mean air pressure or any kind of dehydration. So I'll just go over the echo findings or real patients that we did with similar scenarios. On the top left side, you can see infant during resuscitation. We are actually doing chest compression, and this infant interrupted by this echo view, and you can see that this is typically cardioplegia. There is no any effective contraction in this infant, and you can see the flow of bolus from a line through a central line going to the right atrium and as echogenic bubbles. And this infant required multiple boluses of epinephrine. So this cardioplegia, typically this infant will not wait until someone coming from outside or from home to do detailed hemodynamics assessment. We're talking also about cardiac tamponade. So to do a sweep is very important for infant with pericardial effusion. So you need to see the maximum collection. As you can see here, we sweep from posterior to anterior, and there's a significant collection posteriorly at the back. That's why in urgent technique in this cardiac tamponade, we insert a needle or butterfly for pericardiocentesis directed to the right shoulder and directed also posteriorly 45 degrees. So that will be targeting the main collection at the posterior part of the heart. Now we have another case here. Infant was really very sick, very low oxygen saturation, and also hypotensive because our right side is very dilated, significantly compressing the left side. So there is not enough filling of the left side of the heart with image consistent with severe pulmonary hypertension. Typically in this infant, you have to consult as soon as possible, pediatric cardiologist or expert in hemodynamics, if you are not the one expert in hemodynamics. And then the right side, lower right side, you can see empty heart. And this empty heart, typically this case was infant on very high dose of inotropes, like I think was dobutamine of 20, epinephrine of 1, but not 0.1, 1 mics. And the main intervention in this case just to discontinue the inotropes and give fluids to fill the tank. And there's typically side effect of too much unnecessary inotropes. That could be also due to high minor pressure, or could be hypertrophy related, as we'll see in another case scenario. So we finished with the infant unresponsive to resuscitation. Now we'll talk about hemodynamics in more details. If you have more time to do more detailed assessment by hemodynamics, then it will be the rest of this presentation. And I have divided the presentation into 4 main sections. I'll talk about the physiology of hemodynamics, evaluation of hemodynamics in a crashing infant, phenotypes of hemodynamics or hemodynamic instability in a crashing infant, and then how to select the logical cardiovascular support based on underlying hemodynamic instability pathophysiology or category of shock. So in brief, physiology of hemodynamics, I will ask you this question first. What are the physiologic phenotypes of the crashing infant? So if you move between beds in NICU, if you have 20, 30, whatever number of beds in any intensive care, not even neonatal intensive care, you will get at least one or more of these pathophysiologic mechanisms included in any sick patient. And you realize that everything is related to oxygen delivery. Now we're talking about the physiologic phenotypes. We're not talking about diseases. We're not talking about ARDS or RDS or TTN or chronic lung disease. We're talking about pathophysiologic mechanisms related to either hypoxemia on this side here or hypoxia. So hypoxemia, you have issue related to hypoxemic respiratory failure, which could be limited diffusion due to thickening alveolar membrane, intrapulmonary right to left shunt due to significant consolidation or collapse, hypoventilation due to small lung volume, or pulmonary congestion due to left-right shunt, or pulmonary hypertension. We'll talk about that in a different slide, the different phenotypes of pulmonary hypertension, or VQ mismatch due to inadequate or unequal ventilation to perfusion ratio. And it could be issue related to hypoxia, and the hypoxia is related to the two other remaining components making oxygen delivery. You know, oxygen delivery is related to oxygen saturation. We already discussed that. Hemoglobin and also blood flow. So it could be severe anemia contributing to hypoxia, or could be low blood flow, which is main target of our presentation today. Low preload, low systemic vascular resistance or vasodilatory physiology, high afterload or vasoconstrictor physiology, poor myocardial performance, or left-right shunt. And again, everything is about oxygen delivery. So the next, what determines oxygen delivery? If everything that we are measuring or trying to optimize is related to oxygen delivery. So oxygen delivery is related to the blood flow and oxygen content of the blood, and oxygen content, again, hemoglobin and oxygen saturation, and combining both as oxygen distribution curve, which should be optimized, not significantly deviated to the left, nor significantly deviated to the right, because in either directions you may have very high affinity between oxygen and the hemoglobin, and also in the right side could be very low affinity, which might affect the oxygen uptake at the lung level. So oxygen delivery to the organs and also the organ performance will be can be assessed by oxygen consumption, and we are using for that near-field spectroscopy. That was discussed in a previous presentation. And the blood should be passing back to the systemic circulation through the lung to for reuptake of oxygen. So respiratory function and pulmonary vascular resistance are very important to determine also oxygen delivery. You know that in early in life, during postnatal transition, we may have also either bidirectional shunt, right-left shunt, or left-right shunt that might affect also the hemodynamics and the blood flow. Next question, what maintains oxygen delivery? So we know that oxygen delivery is very important. We need to know exactly how oxygen delivery can be maintained, or the compensatory mechanisms. So as discussed again, we have three main organs that determine oxygen delivery: respiratory system, blood, hemoglobin, oxygen distribution curve, and the cardiovascular system. And everything should be maintained with a normal temperature, normal pH, normal electrolytes. But with any decompensation, for example, if you have decreased the hemoglobin or decreased the blood flow or saturation, the first compensatory mechanism now is autoregulation, which is local vasodilation related to local release of nitric oxide. That's happening within a fraction of seconds. And this autoregulation is different in the brain, different in kidney, other organs, and it is based on the importance and the value of this organ to maintain life or to maintain a specific function. If the autoregulation exhausted, or there is not enough nitric oxide released by RBCs to maintain for hypoxic vasodilation, then the increased oxygen extraction will be the next compensatory mechanism. So you will see the mixed venous saturation dropped because the tissue will extract more oxygen. This can be detected, as you know, by near-infrared spectroscopy. And this is the main value of using near-field spectroscopy in assessment of hemodynamics. But later on, if the oxygen delivery is still very low or decreasing below the aerobic metabolism, below the threshold of aerobic metabolism, then we'll see lactic acidosis, which is really late. We'll see more aerobic metabolism, and we'll see more organ dysfunction, and that might be permanent organ dysfunction, and eventually death. Next question, what determines blood flow? Now we discussed the oxygen delivery is our goal to be maintained, and we discussed the compensation or compensatory mechanism for oxygen delivery. We discussed the hemoglobin, oxygen saturation, and the blood flow, three of them making the oxygen delivery as a value. Now we'll focus more and more on our target, which is hemodynamics, or the blood flow, which is one of the components of oxygen delivery. So what determines oxygen delivery? There are so many factors, but I will just mention about the primary factors that determine blood flow. Preload, afterload, and myocardial performance. So preload typically is a volume of blood received by the heart as a venous return. And this volume will make the end diastolic volume. So there is a remaining volume at end systole, and there is another added volume to make the end diastolic volume. And there is 3 factors to maintain normal preload. The first one, we should have adequate blood flow or blood volume in the body. So the overall blood volume should be adequate and should not be dehydration or low blood volume. Either that could be decreased due to third space losses or due to outside loss of volume due to high urine output or diarrhea or whatever other reason, or could be vasodilatory shock, so stagnation of the blood in the arterial blood due to vasodilatory shock. Lung ventilation should be matching lung perfusion, which ventilation perfusion matching should be between 0.8 and 1. So that's another factor important, because if you have higher resistance through the lung, then the venous return will be less. The ventricular compliance, which is the diastolic function of the ventricle, should be normal. So the ventricle should not be stiff. The compliance should be normal. And sometimes we are using medication to improve compliance, like Merinon. So if the preload decreased, tachycardia is expected, and also the next compensatory mechanism might have an increased vascular resistance. We may have increase in vascular resistance as another compensatory mechanism, which is not the mechanism expected to be mature in premature infant. That's why in mildly dehydrated premature infants, that's very easy to see the blood pressure dropped. So increased vascular resistance is expected to be seen in more mature kids or pediatric age group as a result of dehydration. Afterload. So afterload, increased resistance. So normal resistance is should be maintained and is mandatory to maintain blood flow, but high resistance or higher afterload, that will increase the heart workload, and that might lead to LV dysfunction. So LV dysfunction secondary to high systemic vascular resistance, that might be compensated by tachycardia. We will mention that again and again. The first compensatory mechanism in most of the hemodynamic issues in neonates is bradycardia. Tachycardia, or increased heart rate to compensate and attempt to increase cardiac output. It could be also related to pulmonary vascular resistance. If the pulmonary vascular resistance is high, you may see RV dysfunction and RV failure. Combined, which is the worst case scenario, if you have combined high systemic and pulmonary vascular resistance, might lead to biventricular dysfunction and systemic hypotension associated with severe hypoxemia. In this situation, if we see hypotension with significant RV dysfunction, we may use combination of medication like Merinon plus norepinephrine or vasopressin. Now we have also the third factor, which is myocardial performance. We have 3 main phenotypes of poor myocardial performance. We may have poor myocardial performance secondary to high afterload, which expected to affect systolic and diastolic functions. We may have poor myocardial performance secondary to underfilling, which also affects systolic and diastolic functions. We may have intrinsic myocardial dysfunction or cardiomyopathy, which will be detected, as you can see in this parasternal long axis view, as dilated heart with the systemic dysfunction. So in this 4-chamber view, we see poor myocardial performance secondary to high afterload. In this parasternal long axis view, there's underfilling of the heart, which also might affect the systolic and the diastolic functions. In the third image here, parasternal long axis view, we see poor myocardial dysfunction secondary to intrinsic myocardial issues. And the best example of that is cardiomyopathy. Again, early compensation is tachycardia, late compensation is dilated congestive heart failure. Evaluation of hemodynamics in the crashing infant. They will come to the second stage now of our presentation about the evaluation, how to evaluate hemodynamics. I will focus on the main things that everyone should know about assessment of hemodynamics. So components of hemodynamic assessment, including blood pressure, target neonatal echocardiography, and how to make a physiologic phenotypes of hemodynamic instability based on these parameters. Blood pressure has been a big issue. We don't have worldwide acceptable blood pressure reference values until now. We published recently the normative values for the postnatal transition in premature infants, which I think now is a very important step on using a very clear reference values. And when we did that, it's recently published in pediatric research, we included only normative data from relatively stable premature infants. So the inclusion criteria were in infants born at the St. Rachid Center. We excluded outborn infants. And then infant did not receive any transfusion, blood or volume expanders during the postnatal transition. Hemodynamically stable, did not receive cardiovascular support, did not receive PDA management, stable oxygenation, was FiO2 less than 50%, and no significant respiratory failure, not treated, as I mentioned, for PDA, no significant IVH grade 3 or higher, and no early confirmed sepsis, and survived up to discharge. So we have 8 inclusion criteria, and it was really tough. We studied normal blood pressure over 5 years, and we included only 200 infants out of more than 500 admissions. As you can see here, over the first 72 hours of life, the blood pressure is not linear. It is increasing gradually hour by hour until the 72 hours, and after that stabilize. So the same concept in relation to premature infants. 23 is not the same like 24, is not the same like 28 weeker. So the blood pressure is different and increasing with increasing gestational age. And the most important conclusion from the study that regardless, whatever normative table that you are using, the trend is the most important value. Look at the trend. So if you have more than 20% change in the trend for more than 30 minutes, take it seriously. Consider assessment of hemodynamics more detailed by echo or by echo plus near field spectroscopy, and get a very clear answer about a change of the trend. So any infant not following the trend, as I mentioned in the graph, that should be assessed for hemodynamic instability. Next question in our presentation, what are target neonatal echocardiography variables? So to make it easy, I divided the variables because so many variables we need to know, and the master very important variables. You don't have to do 100 measurements, just master and be very competent about certain measurements. Cardiac output, assessment of M mode for LV, performance, end diastolic volume, and also assessment of the shunts, calculation of systemic vascular resistance. So we divided the echo markers into markers related to left side of the heart, right side, PDA shunt, and also the first line management based on your assessment. So first, LV performance related to systolic performance, filling of the heart in the systolic in systolic volume, and also in the diastolic volume, left ventricle output, and calculation of systemic vascular resistance. So, and when we divided also the hemodynamic instability into categories based on that. So it could be vasodilatory physiology. You will see normal systolic performance, good filling, but low systemic vascular resistance. Category 2, vasoconstrictive physiology or high afterload, you will see impaired systolic performance, variable filling, and also low systemic vascular resistance, opposite to vasodilatory physiology, with low cardiac output. Category number 3, we have everything bad and low, impaired performance, variable filling, low cardiac output and low systemic vascular resistance. When we have left to right shunt, we may have normal systolic performance, dilated left heart, high cardiac output from the left side, variable right side, a variable systemic vascular resistance. We are relying on right side output as a systemic blood flow. And then we have underfilling, we have normal systolic performance, or sometimes hyperdynamic with low filling, low cardiac output, and variable systemic vascular resistance. Right side of the heart, the same, we assess systolic performance, including M mode, we assess fraction area change, we assess right side cardiac output. We may expect normal performance in vasodilatory physiology, good filling, and normal also resistance. We may see variable filling and variable performance in category 2 vasoconstrictive physiology, especially we have associated high pulmonary vascular resistance. In this case, in category 3 cardiac dysfunction, we may see impaired systolic performance, underfilling, and low cardiac output. In category 4 left-right shunt, definitely normal performance and normal filling, but low cardiac output from the right side, because the right side cardiac output here is a systemic cardiac output when you have left-right shunt through the PDA. Underfilling, the same as left side, you will see normal filling and normal output. When you have shunt, the shunt, if it is significant, you will see variable everything, but usually systemic performance is normal or even hyperdynamic. You have significant left-right shunt and variable degree of filling. And then the intervention should be like that makes sense in the physiology. Use a norepinephrine. If you have vasoconstrictive physiology, use iноtrope. If you have cardiac dysfunction with low blood pressure, use epinephrine. If you have infant with significant left-right shunt, for sure, use medical treatment for PDA. And volume expanders only if there is evidence of underfilling. So volume is a medication should be used when only indicated. Now we'll come to the third part of the presentation, phenotypes of hemodynamic instability. We discussed now the physiology of hemodynamics, the physiology of oxygen delivery. We discussed the basic assessment of by blood pressure and the variables or categories of echocardiography measurements and according to the left side, right side of the heart, and shunt. And now we'll discuss the phenotypes of hemodynamic instability in a crashing infant. So we have the mean blood pressure directly proportional to cardiac output and systemic vascular resistance. If the in case of we have very low systemic vascular resistance associated with normal or high cardiac output, that's expected in vasodilatory physiology. If we have the opposite, high systemic vascular resistance associated with decrease in cardiac output, this is expected in vasoconstrictor physiology. When you have low both resistance and cardiac output, this is expected in late stage shock or cardiogenic shock. But we may have even more phenotypes other than vasodilatory, vasoconstrictor, cardiogenic shock. We have hypovolemic shock. Typically, there is nothing other than hypovolemia. You need to be aggressive in giving fluids until you fill the tank. And don't consider any tropes in this case, because that might affect filling of the heart. When you have left-right shunt, you have to treat that as just left-right shunt physiology. You may have obstructive shock, and obstruction could be iatrogenic obstruction like high minor pressure, or could be anatomical obstruction like coarctation. In this situation, the management should be related to the anatomy. Could be restrictive physiology, which is the main physiology in infant with pericardial effusion. When you have significant pericardial effusion with significant restriction of myocardial relaxation, in this situation, definitely you have to consider pericardiocentesis, as we discussed before. So let us put the blood pressure and basic echo parameters together. And we'll start first with the vasodilatory physiology. When you have low diastolic blood pressure, the pulse pressure should be normal. And now I have to be very clear, and I remind everyone, the systolic blood pressure is not the parameter, is not the pressure that reflect the systolic performance. It is the pulse pressure, because the systolic blood pressure is the sum of diastolic and pulse pressure. So if the diastolic blood pressure drops, you will see the systolic blood pressure drops at the same time, parallel to it, exactly as you see here in this paragraph. So here you have the three lines of the blood pressure, the systolic, diastolic, and mean blood pressure. The diastolic blood pressure drop, and the systolic parallel to it, but the pulse pressure maintained. This is typically the vasodilatory physiology. So it is very common misinterpretation or misconcept, considering that systolic blood pressure is the pressure that reflects the systolic performance. It is the pulse pressure, not the systolic pressure. Again, you will see the stroke volume is getting higher trend cardiac output because of the hyperdynamic heart performance, as you can see here in this parasternal long axis view. Typically, in this case, you don't have to give any troops. You need to give only vasopressor. Just after start of small dose of vasopressin or norepinephrine, you can see the trend is going up. Looking at the trend is very important. You can see real-time decrease in the trend and the increase immediately after start of the medication. Common scenario, septic shock. It is the most common mechanism in septic shock or systemic inflammation like neck, late onset shock. Medications can be secondary to medications like vasodilators like morphine, anesthesia. Acidosis might cause vasodilatory physiology and also might happen in HIE. And typically calculated systemic vascular resistance is expected to be low in this case. In vasoconstrictor physiology, as you can see here, diastolic blood pressure trend is normal or going up. With narrow pulse pressure, systolic blood pressure is expected to be low, with low stroke volume, increased heart rate, and low cardiac output, and high calculated systemic vascular resistance. As you can see here in this for a chamber view, impaired myocardial performance. And you can see also in the blood pressure trend, the diastolic blood pressure trend is up with narrowing. Again, pulse pressure is very helpful to look at, very narrow pulse pressure, as you can see here in the trend. If you look at the mean blood pressure, typically in this scenario, you will not detect the hemodynamic instability, only when you look at the pulse pressure. After start of Merinon, the blood pressure actually dropped, but was widened pulse pressure and normalized overall hemodynamics. It is common on failure postnatal transition or failure postnatal adaptation, post-PD ligation syndrome, although we are not ligating PDAs in our center anymore, post-AV malformation embolization, pulmonary hypertension, HIE, and sometimes septic shock, although it is uncommon in neonates, more common in pediatric age group. In cardiogenic shock, everything is low and bad. Low pulse pressure, low diastolic blood pressure, low systolic blood pressure, low stroke volume, low cardiac output, and normal to low systemic vascular resistance. As you can see here, poor myocardial performance in this parasternal long axis view. And you can see the blood pressure trend. The blood pressure collapses and very narrow pulse pressure. In this situation, we may consider medication like epinephrine to help in both systemic vascular resistance and myocardial performance. Common causes, low preload, failure postnatal adaptation late, if you are not able to detect the case early, may progress to cardiogenic shock, pulmonary hypertension, myocardial dysfunction, mechanical ventilation with high minimal pressure, progressive acidosis, overdose of inotropes. Typically, in this case, you have just to discontinue inotropes instead of adding more medications. It might happen also in arrhythmia. Now we'll come to the next question. What about the trend of the hemodynamics related values? As I mentioned, the trend is very important in blood pressure. It is very important in everything else. So normally we should have everything maintained between 10th and 10th centile. Even if you don't have centile, look at the trend of the diastolic blood pressure pulse pressure, perfusion index, which is very small number on the monitor, but it's very helpful to detect, especially when the number is low, poor perfusion, systemic vascular resistance, cardiac output, and tissue saturation by near-field spectroscopy. When you have vasodilatory shock, you may have low diastolic blood pressure, normal pulse pressure, high perfusion index or trend high. So what you can see here is a trend higher or trend low, systemic vascular resistance, trend high cardiac output, and variable tissue oxygen saturation. And vasoconstrictor physiology, trend of higher diastolic blood pressure, trend of low pulse pressure, trend of low perfusion index, high systemic vascular resistance, trend of low cardiac output, and variable tissue oxygen saturation by NIRS. Cardiogenic shock, everything is low, or everything trending low. And left-right shunt, we may have trend of low diastolic blood pressure, but high pulse pressure, or trend high pulse pressure, trend high perfusion index, high left cardiac output, low systemic vascular resistance, and the trend of low tissue oxygen saturation. Volume depletion, you may have low to normal diastolic blood pressure, but low pulse pressure or narrow pulse pressure, trend of low perfusion index, low cardiac output, high systemic vascular resistance, because in volume depletion, as I mentioned before, the vascular resistance expected to increase to compensate for the dehydration or volume depletion, and variable tissue oxygen saturation. Now, what are the mechanisms of hemodynamic instability in arrhythmia? In just one slide, typically arrhythmia should be managed and treated by pediatric cardiologists. But just to understand, in tachyarrhythmia, and also in bradyarrhythmia and tachyarrhythmia, we expect underfilling because there is not enough time for filling. Later on, low cardiac output. Later on, for untreated tachyarrhythmia, we'll see low coronary filling. And then in very late, if tachyarrhythmia continued for a few days without treatment, you will see myocardial dysfunction, which is unexpected scenario. Bradyarrhythmia, typically because heart rate is important to make the cardiac output, you will see low cardiac output, low systemic blood flow, congestive heart failure, low end organ oxygen delivery at the end. If you left bradyarrhythmia for a long time, we're talking about heart rate less than 60 or sometimes less than 50 per minute. If it is prolonged for like days, weeks, you may see at the end low oxygen delivery at certain organs. And we have seen bradyarrhythmia complicated with chronic ischemia of the bowel or chronic kidney injury. Next question. Now I'm getting almost at the end of my presentation. What are the phenotypes of hypoxemia and pulmonary hypertension? In just one slide, we'll go over the 5 main phenotypes of pulmonary hypertension. So don't use pulmonary hypertension as the same terminology as PPHN. They are totally different. PPHN is just failure of decrease of pulmonary vascular resistance after birth to physiologic values. But pulmonary hypertension can be with high pulmonary vascular resistance, can be with high pulmonary blood flow, which is the opposite. But let us go over the 4 phenotypes. So we have high pulmonary vascular resistance, which is mainly PPHN. Management typically optimized ventilation, target saturation 90 to 95, with pulmonary vasodilators, which is typically we are using nitric oxide. And if it is late or severe, you may have high pulmonary vascular resistance with RV dysfunction. We just add to whatever we mentioned, dobutamine. In very severe cases, we may use prostaglandin to reopen the duct. But you may have LV dysfunction with pulmonary venous hypertension, with more stagnation or more blood in the venous compartment. We should not use, in this situation, nitric oxide. We may even accept a little bit lower target saturation. In this situation with LV dysfunction, especially if the PDA is open right to left, if you use nitric oxide, you will worsen the systemic blood flow even further, and you will worsen the pulmonary venous hypertension. You should not use nitric oxide in this case. You may use dobutamine or merinone, but not both at the same time, and optimize ventilation for sure. You may maintain the PDA right-left shunt until you get the systemic blood flow normalized and the LV performance improved. So don't use nitric oxide with LV dysfunction. If you have both ventricular dysfunction, again, use medication to improve both performance like dobutamine or merinone, but not both at the same time. You may accept a little bit lower target saturation, but don't use nitric oxide until you improve the LV performance. The last phenotype is kind of rare, but you may have transient RV hypertrophy with very low pulmonary blood flow. That might happen with premature intrauterine PDA closure. If mother received antenatal steroids, received non-steroidal anti-inflammatory before birth, the PDA might close antenatally, and that might cause significant reduced RV filling, and you may see severe RV hypertrophy with reduced flow. It might resemble actually RV hypoplasia. You don't have to do anything other than accept lower target saturation, 75 and above. You may consider prostaglandin in this case. Don't use nitric oxide and just use adequate fluids. And cardiovascular medication, we have 4 or 5 main phenotypes. Vasopressors should be used in vasodilatory physiology, vasopressin or norepinephrine. In cardiogenic shock, use inotrope with vasopressor effect like dopamine or epinephrine, although most of the ANS now not using dopamine and you are using epinephrine instead. Vasodilatory shock, you may use epinephrine, but is not the preferred medication. Inotrope with vasodilatory action like dobutamine or merinone should be used in vasoconstrictor physiology or cardiogenic shock. Fluids only if you have hypovolemic shock, not just given as empiric to everyone. Steroids if you have refractory shock. Infant who is not responsive to first line of medication and you are about to add another line, you can consider steroids as infant is not responsive to the cardiovascular support. I already shared with you some questions, so just to go over the 3 questions quickly over the next few minutes, will be the last few minutes in my presentation. The first question about an infant with IDM admitted to NICU with hypoglycemia on day 2 developed oliguria with normal pulse pressure. And I think it's easy to realize the feeling is very poor. You have severe hypertrophy, and this is the main reason. So you expect severe hypertrophy for a chamber view or parasternal long axis view or even short axis view. Typically in this case, you have to give only fluids. And sometimes we'll give beta blockers to slow the heart rate to maybe 100 or 110. That will give more chance for the heart or the ventricle, more time for filling, and that might improve the hemodynamics and improve urine output. Don't give inotropes in this case. The worst case scenario, if the blood pressure dropped significantly, you may use low dose of vasopressor, but no inotropes in hypertrophy. The next question about premature infant 27-weeker with 2 days old with maternal preeclampsia with low cardiac output, low blood pressure, high systemic vascular resistance. Typically, how to calculate it is very easy. You need to just divide the cardiac output in liter per minute, not in milliliter, by mean blood pressure. The fractional shortening was low, perfusion index was low, and tissue oxygen saturation was low. So this infant was actually decompensated with increased oxygen extraction, so the autoregulation has been lost. That's why you see the near-field spectroscopy, oxygen saturation is low. So what's underlying physiology in this case? It is vasoconstrictor physiology, impaired performance, and typically we used dobutamine, low dose of dobutamine, which was enough. Question number 3, we have 36-weeker HIE and cooling protocol, develop hypotension, as you can see, and near-field spectroscopy also showed low trend of oxygen saturation, although we may not see that in HIE, but the HIE was not bad. That's why the oxygen consumption was Okay. And when the blood pressure dropped, the cerebral oxygen saturation dropped at the same time. And as you can see here, the trend of the blood pressure dropped was maintained the pulse pressure. So again, when you see that the systolic blood pressure dropped or decreased and the systolic blood pressure dropped at the same time parallel to it with normal pulse pressure, this is vasodilatory physiology. So don't consider low systolic blood pressure as a marker again for low systolic performance. It is a pulse pressure. So after use of vasopressor here, you can see the blood pressure improved. And the calculated systemic vascular resistance was low. So you may ask me about the evidence of using hemodynamics in our unit. We compared 3 years of complete epoch of assessment relying on echocardiography, near-field spectroscopy, and the detailed assessment of hemodynamics compared to a different epoch before we started our hemodynamics program. And that was like validation as a quality to prove that hemodynamics assessment made a significant difference. So we assessed all infants with pulmonary hypertension with shock and with the PDA, and just showing here the survival curve with the 2 epochs. So you have significant reduced the time to clinical recovery, almost half the time to clinical recovery compared to the first epoch for all infants diagnosed with shock with lower trend of deaths, although the total number was not enough to sample was not enough to consider death as an outcome. You can also visit our website. You can also use this clinical decision support system on new Pizot Academy. It is also available as app on App Store, and you can use this app to help you in assessment of the blood pressure centile values, in assessment of systemic vascular resistance, and also can help you in making decisions at the end. It is available on App Store. I have 3 main conclusions at the end, and after that, I'm happy to listen to you, all of your questions. So understanding the physiology of hemodynamics is very crucial step for proper management of hemodynamic stability. Before learn echocardiography and other technical details, you have to understand physiology very well. Integrated clinical T and echo, and also if you have near-field spectroscopy, this integrated model is helpful to formulate physiologic-based medical recommendation. And then hemodynamic evaluation is proven to shorten the time to clinical recovery if we are asking about the evidence of using hemodynamics compared to not using hemodynamic assessment in your practice. Thank you very much. I would like to thank everyone in the slide, including Dr. McNamara, who's my first mentor in hemodynamics, Dr. Seshia, Dr. Michael Narvi, Shamla, my colleague, and Dr. Abdul Wahab from McMaster University, and all of my colleagues, the second row, all of my colleagues in Winnipeg, that are like really, they are really involved deeply in assessment of hemodynamics and point of care in our unit. Thank you very much.